Hi, this is Dr. Edward Halpern from New York Medical College and Touro University, and welcome back. We're on the air again with the New York Medical College, Touro University webinars, 90 Minutes, the medical magazine of the web, where we strive to give both healthcare practitioners and interested current and potential patients up-to-date information on healthcare from experts on our faculty. This is our 31st webinar, and we have picked a topic for today of common things that people in healthcare do and that we acquiesce to have done. Are they really evidence-based medicine, or are they what we sometimes call in medicine lore, custom, but don't have firm evidence? I've invited a group of speakers, which includes some of your old friends from previous webinars and some new friends you haven't met before, to tackle some of these common subjects. You're going to have a visit again with an old friend, Dr. Karen Murray of the Department of Obstetrics and Gynecology. I've asked her to talk about whether it really does or doesn't make a difference for maternal safety and child safety about whether childbirth occurs in the hospital or at home, because of a trend among some folks to insist on giving birth at home, sometimes in the presence of a coach or a doula or a midwife, but without the presence of an obstetrician gynecologist at a hospital setting. Then I've asked another old friend who you've met from previous webinars, Dr. Tammy Hendricks, a pediatrician and dean of the Touro College of Osteopathic Medicine in Vallejo, California, to talk about another tradition in medicine. Nope, you can't take the baby home after the baby's born until the pediatrician says so. Well, is that newborn physical examination, which is the tradition of American medicine, really evidence-based? What are they looking for? How likely are they to find it? And does it really make a difference in the healthcare of children? We're then going to turn our attention to adult medicine. And I've asked two speakers to join us because there are some physicians who consider part of a routine yearly physical the so-called routine chest X-ray and the routine electrocardiogram. Well, they may be routine for some people, but are they actually proven to make any difference in people's healthcare outcomes? From New York Medical College's partner, the Metropolitan Hospital in East Harlem, Dr. Trinard's going to talk with us about what's the value of a chest X-ray as part of a routine examination. And Dr. Jason Jacobson for the Division of Cardiology at Westchester Medical Center is going to chat with us about those so-called routine electrocardiograms. Are they really useful or not? Then to wrap up from our speakers, we've got a topic that I think is going to interest a lot of people, and that is the cabinet full of vitamins in your house. And an industry in the United States that is enormous, churning out all kinds of vitamins. Does the average person need to be swallowing all those vitamins? Or should we just do what lots of people say, which is eat a balanced diet, and we can say, forget about all those vitamin pills? I've asked Diane Lindsay Adler to join us. She is a nutritionist and an adjunct member of the faculty at New York Medical College, and she's going to talk about what the evidence is about vitamin consumption. And then, as always, we'll be turning our attention to your questions. If you have any questions for any of our panelists as the lectures are going on, go ahead and type them in the Q&A box on your screen. We will take a look at them, and we will get to as many of them as possible during the Q&A part of our program. For those of us watching this program seeking continuing medical education credit, I will appear at least twice in between the talks to tell you exactly how to sign up for your CME credit. As always, we hope you will enjoy the program, find it educational and useful. Thanks for joining us, and let's get started with our first speaker.
Hello, I'm Karen Murray, Dean of Admissions here at the School of Medicine at New York Medical College and a practicing obstetrician. I'm here to try to shed some light on the question of, does it really make a difference in mother and child safety to give birth in a hospital rather than at home? I have no disclosures. The National Center of Health Statistics states that there's about 1% of births that happen in the United States at home. Of those births, about a quarter of them are unplanned. In developed countries, birthing in a hospital is the cultural norm. This shift occurred during the 20th century, because if you look back into, say, the 1920s, 1930s, in the UK, about 80% of women gave birth at home, and about 50% of women in the US gave birth at home. Now there's fewer than 1% in the US and about 2.3% in the UK. New Zealand, however, has a slightly higher rate. Today, they are about 2.5%. And in the Netherlands, about 20% of births still occur at home. These births are primarily attended to by midwives. Dutch midwives are licensed practitioners and really take care of most of the low-risk pregnancies in the Netherlands. They really only refer high-risk pregnancies to the obstetricians. Although births in the US and the UK have remained low, in the recent years, there's been a trend to more folks trying to give birth at home. So if you look at the numbers, even though they're small, they've just about doubled. The Royal College of Midwives, as well as the Royal College of OBGYNs in the UK, issued a joint statement that supports home births for women with uncomplicated pregnancies. However, there are different viewpoints in the United States. Nurse midwives support informed choice and access to home births. However, the American College of OBGYN, as well as the American Academy of Pediatrics, still maintain that a hospital or a birthing center are the safest place for women to give birth, regardless of their risk status. So why do women choose to give birth at home? Sometimes it's accidental. They have lack of transportation or no local hospital. It may be cultural or religious. And for the most part, patients are looking for comfortable and familiar surroundings to bring their child into the world. It also gives them more control over their birth process. So when you think about giving birth at home, you set up a room or you set up the home in a way that's welcoming, soothing to both the birthing mom and the newborn baby. A good candidate for home birth is someone who's had a low-risk pregnancy, that has a single pregnancy, and this baby is now head down, and there are no other concerns during the pregnancy. As you prepare for a home birth, it's good to choose a well-qualified healthcare professional, such as a certified nurse midwife. And the American Academy of Pediatrics also recommends just having someone there who's a trained person just to take care of the baby. So the baby having their own caregiver at the time of birth. You could also consider hiring a professional labor assistant or a doula. Now, doula training varies within the United States. Doulas of North America, they have a 16-hour course, and then you become a certified doula. Their training is evidence-based, so is the training that's done by CAPA. CAPA gives like a training class followed by 2 years to have hands-on training before being certified. And in New York City, there's a citywide doula initiative where they offer free training every year to community members who'd like to become doulas. When you think about giving birth at home, it's always good to be prepared. You want to create a birth plan. And in your birth plan, you should kind of think about, who do you want to be with you when you give birth? Where do you want to give birth? How do you want your surroundings to appear when you give birth? What equipment will you need when you give birth? Making sure that you get all the equipment you need. Maybe taking a childbirth class would be very helpful. That way you can educate yourself on giving birth at home. Think about whether or not you're going to want to have some kind of pain medication. And you really want to prepare yourself both mentally and physically for this challenge of giving birth at home. Another caveat to that is think about what would happen if something goes wrong and I do need to go to a hospital. So you should, discuss with your healthcare professional, having a connection with a local hospital that's no more than about 15 minutes away, who has a 24-hour labor and delivery and an obstetrician available to take care of you in case you do need to transfer your care to a hospital. Also, keep in mind you may want to check with your insurance company because many insurance companies do not cover home births. How do you know when it's time to transition to the hospital? This usually happens if your labor is not progressing, if your baby shows signs of distress, or is in a position that's not head down. If you feel that you need more pain relief than you had originally thought, if you're having high blood pressure, if you experience any kind of bleeding or develop a fever, these are signs that you may need to transfer yourself to a hospital. Some of the disadvantages of a home birth is that no matter how well you've planned your home birth, it's really not for everyone. Um, some of the drawbacks can also be the time and energy and the cost involved in preparing for home birth. Again, if you have to transfer to a hospital, now you're delivering with a team with whom you're not familiar. You've never met them, they've never met you until you come in to have your baby. You also have to make sure you have arrangements in terms of transportation to the hospital while you're in active labor. Are you going to go in a personal car? Are you going to go in an ambulance? ACOG also estimates that about 37% of first-time moms who opt for home birth are eventually transferred to a hospital setting. So what are the advantages of the hospital birth? Again, the literature says hospital births decrease the risk of neonatal death. The hospital does provide resources in an emergency. It's a safer place to give birth. They have resources that you may be able to use before, during, and after your baby's born. They have a wider variety of pain management options. And they also have access to other resources such as nursing and lactation support during your stay in the hospital. Keep in mind, many health organizations are really trying to change the way they look at birth and moms and delivery. Many hospitals have an OBGYN certified nurse midwife alignment. So you could still have your midwife with a backup obstetrician in the hospital. They're trying to figure out ways to personalize everyone's birthing experience. The hospital culture, birthing culture is changing. So you really should do your research, do your homework, try to find the right combination or the right fit of provider or hospital that may work for you. Many hospitals are undergoing construction and they're starting to change their labor rooms to look more like delivering at home. There are tubs available. It's more welcoming and it's more friendly. They're making it more family oriented, a place for the entire family to be shortly after mom gives birth and when mom is on the postpartum unit. Some of the disadvantages of a hospital birth is the lack of intimacy and familiarity, the visitor limitations, the policies around visitors, length of stay, and basically feeling like you've given up control when you're in the hospital. Many moms come into the hospital and feel alone. They feel that they don't have adequate support. There's lots of interventions that occur, and they really feel like they don't have the support of the peers that they want and the family members that they may want to have around them. So, when do you think it's a good time when is a home birth recommended? So again, it's usually if you've had one baby, if the baby is head down for delivery, and if you've not had a C-section in the past. Having a vaginal birth after a C-section is a very risky endeavor. There is a risk of complications that could happen and may require emergency intervention. So it really is not recommended to have a birth at home if you've had a previous C-section. So in summary, home births let you have more control over your birth experience, often resulting in fewer interventions. However, it requires extensive preparation and are associated with a higher risk of death in the newborn. Hospital births are the safest option for having a baby and offer other health resources. However, though safer, hospital births tend to feel less intimate and can come with many restrictions. Talk to your birth team, to make an informed decision that's going to be right for you and your family. We're looking for a happy baby, happy family, happy moms. These are my references. Thank you very much.
Good afternoon, everyone. Thank you for joining me today. My name is Dr. Tammy Hendricks, and I'm the Dean and a Professor of Pediatrics at Touro University, California, College of Osteopathic Medicine. And I'm excited to discuss a topic that touches nearly every family. First checkup. Does the newborn physical exam truly make a difference? We'll explore why hospitals mandate this exam before discharging newborns, the benefits it brings, the challenges it poses, and whether there might be better approaches to ensuring a healthy start for babies. Let's dive in. I have nothing to disclose for this presentation. Let's start with the question. They won't let me take my newborn home from the hospital until after the pediatrician checks the baby. Is a newborn physical examination proven to be of value? Every parent wants their newborn to have the healthiest possible start. This makes the newborn physical exam seem like a crucial step, but it often leads to delays in discharge. Today, we'll examine whether these exams are worth the wait. Are they as effective as we believe in catching serious issues, or are there smarter ways to approach newborn health? Our goal is to explore the evidence and provide a balanced view of this practice. The newborn physical exam is typically conducted within the first 24 to 72 hours after birth. It's a detailed assessment designed to identify any immediate or potential health concerns. The exam focuses on detecting congenital anomalies like heart murmurs or hip dysplasia, which, if untreated, can lead to long-term issues. It also looks for signs of birth trauma, infections, jaundice, or other abnormalities. The goal is simple but critical. Identify problems early to intervene effectively. With modern technological advancements, point-of-care ultrasound that's performed directly at the bedside, has revolutionized medical diagnostics, enabling more precise and timely detection of potential physical abnormalities. Let's talk about the evidence. Research shows that early identification during these exams can make a real difference. For example, congenital heart defects are detected in about 1 in 100 newborns. Glaucoma or retinoblastoma are rare but serious eye conditions that can be detected during the newborn exam. Early detection allows for life-saving interventions. Similarly, conditions like hip dysplasia can be addressed early, preventing serious mobility challenges later. Studies also show that these exams reduce hospital readmissions by 10 to 15%, which not only helps families, but also reduces strain on healthcare systems. These statistics underscore the importance of this exam in safeguarding newborn health. Nurse midwives are trained to perform newborn examinations as part of their scope of practice. While their assessments are thorough, they're typically focused on identifying immediate issues and ensuring that the baby is stable. Pediatricians, however, are specially trained to evaluate complex medical conditions and perform a more detailed examination, particularly for at-risk infants or those with suspected abnormalities. Birth coaches and doulas provide emotional and physical support during labor, but are not medically trained to perform newborn examinations. There's a significant shift in practices across generations. In the past, personal pediatricians often visited the hospitals to examine newborns. Today, this role is frequently filled by hospital-based pediatricians, neonatologists, or family medicine clinicians. Both systems can provide high-quality care, but it is essential to emphasize communication between hospital-based clinicians and baby's future primary care pediatrician to ensure continuity of care. However, the newborn exam isn't without its limitations. Despite its benefits, there's a risk of false negatives. Rare conditions might go undetected, or overdiagnosis, which can cause unnecessary worry. For parents, waiting for these exams can cause stress, especially when delays impact their plans to go home. On a larger scale, conducting these exams for all newborns requires significant time and resources, which raises questions about their cost effectiveness, particularly for low-risk infants. As pediatricians, our role during the newborn physical examination in the hospital is vital, especially since this is often the only time we get to speak with parents before they head home with their baby. This brief interaction provides an essential opportunity to address key topics that'll help parents navigate the early days of their child's life. First, we need to guide parents on feeding, ensuring they have the right information to support the baby's nutritional needs. We also cover emergency precautions, helping them to recognize signs that might require immediate attention, and safe sleeping practices to prevent risks like sudden infant death syndrome. Finally, we stress the importance of follow-up care, emphasizing that pediatric checkups are crucial in these early weeks to monitor growth and development. These discussions are critical because in many cases, this is the only opportunity to connect with parents before they leave the hospital. So it's important that we address these topics thoroughly and compassionately. Let's consider how this impacts families and clinicians. For parents, the exam can bring reassurance, knowing their baby has been thoroughly checked before going home. But the waiting can also add stress, especially if they're unsure about what the exam will entail. From a healthcare clinician's perspective, the exam is an opportunity to catch critical issues early. But balancing thoroughness with efficiency can be challenging, especially in busy hospital settings. This balance is essential to maintaining trust and ensuring the best outcomes for families. As we look to the future, are there alternatives to the traditional newborn physical exam? One promising avenue is remote neonatal assessments using digital tools, which could allow for quicker, more accessible evaluations. For low-risk newborns, streamlining discharge procedures with follow-up visits might make more sense. Enhancing parental education on warning signs could also empower families to monitor the baby's health effectively at home. These approaches could reduce the strain on hospitals while maintaining safety for newborns. So, does the newborn physical exam make a difference? The answer is yes. It provides reassurance for families and occasionally catches critical issues that could have long-term consequences and allows for time for the pediatrician to educate the new parents. That said, its full value lies in combining medical benefits with a family-centered approach. As we continue to evaluate and improve practices, it's essential that we ensure that they remain evidence-based and adapt to meet the needs of both newborns and the families. Thank you for your attention, and I encourage you to think about how we can collectively advance this critical aspect of newborn care.
Hello again, this is your host, Dr. Edward Halpern from New York Medical College and Touro University. And it's time to talk about how to get your continuing medical education credit for those of you seeking CME credit for today's program. You've got two choices, but whichever choice you use, you'd better make it a note on your to-do list to go ahead and do it because the code will expire on Sunday, December 15th at 1 o'clock. Your first choice is to get out the cell phone and type in a message to 828-295-1144. And in your text, send the code 43HOLP, 43 HOLP, HOLP. If you do that, you're going to get a text message back with instructions as to how to fill out your satisfaction questionnaire with today's program and how to get your CME credit certificate emailed to you. If you don't like that technique and you're high tech, you can use your QR code reader on your cell phone or your iPad or your laptop, and you can scan the funny looking checkerboard on the screen. And what it will do is it will automatically take you to our website. And once again, you can fill out your satisfaction questionnaire and you can get your certificate for your CME credit for today's program. We offer this CME credit as a free service of New York Medical College and Touro University. And we hope those of you seeking credit will avail yourself of the opportunity. But as I said, you've got about 3 days to do it before the codes expire. Now, we're going to go back to our program, but remember that if you have any questions for any of our panelists, go to that Q&A box on the screen, pose your questions, and we'll get to as many of them as possible during the Q&A part of our program. Once again, thanks for joining us, and let's return to our program.
Hello, everyone. So my name is Natushka Trenard. I am a pulmonary critical care physician for Metropolitan Hospital, New York City Health and Hospitals, and I'm going to be answering the question for you. My doctor says that a chest x-ray should be part of my yearly physical. Is that evidence-based medicine? So I have no disclosures. And today, very briefly, I'm going to take you through some old data that helps us get some background and context to provide, some information as to why we should or should not get an x-ray as part of our routine health exam. Inevitably, I have to touch on lung cancer because it is the motivation why maybe many physicians may recommend a chest x-ray on routine examination. We'll talk about lung cancer screening, some of the newest guidelines, and what you should be aware of during your clinic visit. So as a pulmonologist, I wanted to sort of give you two cases where you would see why I would order a chest x-ray. So both cases and both patients are symptomatic patients. So the first is Ms. Jenkins. She's a 50-year-old female, never smoker, who presented for an annual exam and reported persistent cough, productive sputum. The sputum was changing in color. Now it's green, and she's been having subjective fevers. Or Mr. Luther. He's a 65-year-old male that presented with worsening shortness of breath and lower extremity swelling for about a month. So in these instances, I would be ordering an x-ray to look for any acute abnormalities, things that would explain the cause of their symptoms. And of course, any progression of abnormalities if I had a previous x-ray to compare. However, these subset of patients, I would not be thinking about a physical exam, about a chest x-ray. So this is Miss Todd. She's a 55-year-old female, who's a non-smoker without any complaints, who presented for an annual physical. She has a family history of cholangiocarcinoma. Her exam was unremarkable, but she tells me that her physician in Florida convinced her to have a chest x-ray as part of her routine physical. So in my head, I'm thinking, what is her physician concerned for? And what way is she attempting to use the chest x-ray? So I wanted to talk to you a little bit about screening and lung cancer. So a lot of times physicians will be ordering chest x-ray as a screening modality. And one of their primary concerns in doing so is to see if they could detect lung cancer, right? And I would understand why, as many of us know, why lung cancer would be at the forefront of many physicians' minds. So lung cancer continues to be the leading cause of cancer-related deaths in the United States, and early detection has been shown to reduce mortality, or lung cancer specific mortality, right? So what's the data we have? So these are two old papers, one from 2012 and one from 2016. And they both just look at try to answer the question whether chest x-ray could be useful in routine screening or routine health examination. And both papers pretty much say the same thing. The first one here on the left that I'm showing you had about 4,000 participants, and out of the x-rays that were done, there was a minimal amount that found an abnormality, and then even much less that required any sort of medical intervention. The paper done in Malaysia here shows that there were 5,000 chest x-ray films done, and a very small percentage were considered abnormal. So the driving point here with this older data is that chest x-rays used in screening have very low yield. And if it has very low yield, a lot of the radiation that you're exposing patients to is unnecessary. In addition, there are a lot of false positive screening. So we inevitably have to answer the question, what would make a good screening test, and what is screening essentially trying to achieve? So with screening, you're trying to capture a high-risk patient population, so a patient population that you can identify specific risk factors for a particular type of condition, and you want to catch that condition early, so when patients have no symptoms. So things that comprise a good screening test. So you'll hear the words sensitivity and specificity. So these are markers of whether markers that we evaluate for a screening test. So sensitivity refers to a true positive rate. So it's the probability that a patient with the positive test actually has the disease. And specificity, which is a true negative rate, which is the probability that a patient with a negative test result does not have the disease. So in screening tests, depending on what's the disease that you're trying to capture, you'd want a high sensitivity and a high specificity. You want a screening test that's capable of detecting a high proportion of disease. You want one that's widely available. You want one that's safe, cost-effective, and that improves health outcomes. So the question is, does that exist for lung cancer? What is the evidence base for specifically lung cancer screening, which a lot of times is what the chest X-ray tried to achieve? So in 2011, the National Lung Screening Trial was published in the New England Journal, and it looked at over 53,000 participants who were randomized to either getting a low-dose CAT scan, so much more involved imaging of your chest versus a chest X-ray. And they picked an at-risk population, which included a patient population between the age of 55 and 74, and they're either current or former smokers. And what they found was a 20% relative reduction in lung cancer-specific mortality. So to achieve this reduction in mortality, there was over a 95% adherence rate to the screening cycles, and over 50% of the screening detected cancers were found after that initial screening. So here is a small graph pretty much just summing up what I just stated. And you see here that low-dose CT, the cumulative number of lung cancer deaths with low-dose CT was significantly lower than the ones than the amount of deaths from that were caught with chest radiographs. So that, again, there was a 20% reduction in risk of death from lung cancer with low-dose screening as compared to chest X-ray. So as a consequence of that, there were other unpowered studies that were done, but the National Lung Screening Trial was one of a landmark study that led to the United States Preventative Service Task Force recommending annual low-dose CT for lung cancer screening in high-risk patients. And the current eligibility criteria that we go by is patients that are 50 to 80 years of age. They have to have a 20-year smoking history, and they have to either be active smokers or quit within 15 years. So that this is actually evidence-based guidelines for patients who should be getting lung cancer screening. And so where are we in the state of lung cancer screening? So despite having this good data to support, this evidence-based data to support annual low-dose CTs in patients at high risk, there is severe underutilization of lung cancer screening. So across the nation, the utilization of lung cancer screening varies between 5 and 15%. And we also know that there's higher lung cancer mortality in certain groups. So patients of different racial and ethnic backgrounds, patients of lower socioeconomic status, patients with serious mental illness have higher lung cancer mortality. And one of the important things you should know is that survival and prognosis is dependent on staging. So another point I want to bring up from the National Lung Screening Trial is that most cancers were caught at an earlier stage when caught with low-dose CT versus chest X-ray. And the importance of that is if it's caught early, as you can imagine, the prognosis is much better, the survival is higher. And this is just a slide here to drive home the point that I'm trying to make. So this is some data from a population-based cancer registry, SEER registry. And what it shows, what I'm just trying to show you here is when most patients are diagnosed with cancer, most of them are diagnosed at an advanced stage, right? And the importance of that, again, is that when you are diagnosed at an advanced stage, it significantly reduces your 5-year survival rate. So there are two types of cancers. Cancer can be classified into two types of categories, non-small cell lung cancer and small cell lung cancer. And what you see here, what's circled here, is that when the diagnosis is made and there's distant disease, meaning there is metastasis, you see how the 5-year survival rate precipitously goes down for both types of cancers. So the point here is that lung cancer screening, the way it reduces mortality is by catching it early. So a patient that I would routinely be getting a lung cancer screening test, or I would be doing chest imaging on, that did not have any symptoms, would be this classic patient here. She's a 50-year-old female. She's an active smoker. She has a 20-pack year smoking history without any complaints, who presents for an annual exam. This is a patient that would be getting a low dose CT, and there's evidence-based data to support doing so. So back to our question. My doctor says that a chest x-ray should be part of my yearly physical. Is that evidence-based medicine? So the answer is no, but there is lung cancer screening modalities that has a lot of data to support its use, its annual use, and how it can reduce mortality by 20%. So there is evidence-based lung cancer screening available, just not with chest x-ray. Thank you.
Hello again, this is your host, Dr. Edward Halprin, telling you how you can give back to New York Medical College, because programs like the one you're watching and listening to today, and the research with underpins what we're talking about today, all take time and effort and money. You'll notice we never charge for the CME credit, for example, for these programs, but there are real costs to creating these programs. We hope you'll consider making a tax-deductible gift to offset our costs. Great things are happening at New York Medical College and at Touro University. We hope you'll want to be a part of it. There are 3 ways to make a donation to support webinars like the one you're watching now. You can phone 914-594-2720. And a friendly, happy person at the Development Fundraising Office will be more than happy to take your information and your credit card information to make a donation. If you'd like to do it online, go to the website www.nymc.edu/give, and you can make the donation online. And if you are a believer in checkbooks and pens, like me, you can make your check payable to New York Medical College, write in the memo line support of the webinars, and put it in an envelope with a stamp and send it to New York Medical College, Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. We do want to thank you in advance for thinking of us and supporting these programs. Stay safe and healthy. If you have any questions for any of our panelists, please type them in the Q&A box on the screen, and we'll get to as many of them as we can during the Q&A part of our program. And now let's get back to our program.
Hello, and thank you for inviting me to speak on this webinar. My topic today is my doctor says that an ECG should be part of my yearly physical. Is that evidence-based medicine? I'm Jason Jacobson, and I'm the Director of Complex Arrhythmia Ablation Program at Westchester Medical Center. I'm a cardiac electrophysiologist or heart rhythm specialist. So my title is maybe distilled best down to what is the benefit of a screening ECG? I have no relevant disclosures for this topic. So really, very quickly, I think it's worth mentioning that the heart is an electrical organ, meaning that in order for it to squeeze or beat, it needs an electrical signal to tell it to do so. Now, there's an elaborate electrical system of biological wires that helps bring that signal throughout the heart so that it can contract in a nice coordinated fashion. The electrocardiogram is essentially a display on the body surface of the electrical activity of the heart through a number of electrodes that are placed on the body. This can show us the signals from the upper and lower chambers, and also can help us imply the health of the conduction system, and also help us diagnose different arrhythmias, both too slow bradycardia or too fast tachycardia. Now, the standard resting ECG is done with the patient lying at rest, and it's taken over about 10 seconds and has 12 leads. However, the ECG can be done during exercise, which is your common treadmill exercise test, and even can be done over days to weeks as an outpatient on an ambulatory ECG monitor. Now, this is what an electrocardiogram looks like. And I mentioned there are 12 leads, and each lead takes a different look at a different part of the heart, which helps us diagnose which area is having the problem. So the screening ECG, the purpose of a screening test is to identify disease in asymptomatic individuals without a diagnosis. The screening ECG can detect evidence of coronary artery disease, cardiomyopathy or abnormal heart function, hypertensive heart disease, genetic disorders that can lead to cardiomyopathies or different arrhythmia syndromes. The screening ECG can also actually diagnose arrhythmias, as I mentioned, either due to conduction disorders, ventricular tachycardias, or supraventricular tachycardias. Now, most screening ECGs are done to primarily distinguish if patients have any evidence of coronary artery disease, hypertensive heart disease, conduction disorders, or asymptomatic atrial fibrillation or flutter. Cardiovascular risk very much depends on the baseline population features. So the value of a screening test very much depends on this baseline risk. If a population has 0% risk, there's going to be very little value to a screening test. There are many risk factors for cardiovascular disease, including age, sex, obesity, hypertension, diabetes, smoking, elevated lipids, inactivity, and even race. There are a number of cardiovascular risk calculators that have used these risk factors in a weighted fashion to develop a complex equation. The most commonly used current risk calculator looks at 10-year levels of risk, with low risk being less than 5%, high risk being greater than 20%, and intermediate risk being 7.5 to 19.9%. So this is a screenshot from the American College of Cardiology website where this clinical risk calculator is available. Basically, you plug in a number of features about the patient and click on some radio buttons, and it will give you your 10-year risk profile for that patient. And this would be a low-risk patient at 4.8%. Does an ECG add value to the clinical risk calculator? Well, some studies do show additional predictive ability with an ECG, either compared head-to-head with these different clinical risk scores or combined with these clinical risk scores. However, no randomized trials have shown benefit to screening ECGs because they haven't been done. On the left here, what we have is the addition of the ECG to that clinical risk model that I showed you. And what they looked at was in patients that had cardiovascular events or didn't have cardiovascular events, did adding an ECG change the reclassification of the patient to a different risk group? And in patients that had events, it actually did increase the number of patients that were at higher risk than they might have been with just a clinical risk factor calculator. However, in patients that didn't have events, there wasn't that much of a change. But really, we want to identify higher risk patients. So this does show some benefit. In this study from 2016, the group looked at the ECG risk score versus head-to-head two different clinical risk calculators. And while they did find that the ECG did show maybe even better predictive accuracy for ischemic heart disease death, cardiovascular death, and death in general, it wasn't a huge amount of improvement. So what about just looking at a low cardiovascular risk population? This was a study most recently in the Annals of Medicine 2023, where they looked at ECG alone. They looked at two different clinical risk models, and then they looked at the combination of those clinical models with ECG. And they did find that combining all of these did improve the predictive accuracy for defining this low-risk population into maybe, intermediate risk or higher risk populations. So does that turn into benefit? Well, this study from 2017 looked at a large group of patients that were low risk, undergoing an annual health examination, some of which received ECGs within 30 days of that health examination, the majority of which did not. And what they found was the patients that had ECGs had a much higher rate of utilization of cardiovascular services, including consultation with the cardiologist, echocardiograms, stress tests, and even cardiac catheterization. However, when they looked at outcomes, specifically death, having that ECG did not decrease the death rate. It actually seemed to be associated with an increase. They also saw greater utilization of cardiac hospitalizations and revascularization, because if you start doing all these tests, you're probably going to find things that you start to follow up on, which acting on these might not necessarily change a patient's outcome. So that leaves us with recommendations from the U.S. Preventative Services Task Force from 2018. And I think it's important to realize that these recommendations are pretty much in line with a number of societies, both from primary care as well as cardiology. And the recommendations are that patients who are at low risk of cardiovascular disease events should not undergo a screening ECG, either resting or exercise. Now, patients at intermediate or high risk of events, there's really no recommendation because the evidence is very much insufficient. So the take home, the ECG is the first test performed for patients with symptoms of cardiovascular disease. However, yearly routine ECG should not be performed in asymptomatic patients with low risk for cardiovascular disease. However, the role of screening ECGs in patients at intermediate or high risk for cardiovascular disease remains uncertain. Thank you for your attention today, and I hope this answers some of your questions.
Hello again. This is your host, Dr. Edward Halpern from New York Medical College and Touro University. And it's time to talk about how to get your continuing medical education credit for those of you seeking CME credit for today's program. You've got two choices, but whichever choice you use, you'd better make it a note on your to-do list to go ahead and do it, because the code will expire on Sunday, December 15th at 1 o'clock. Your first choice is to get out the cell phone and type in a message to 828-295-1144. And in your text, send the code 43 HOLP, 43 HOLP, HOLP. If you do that, you're going to get a text message back with instructions as to how to fill out your satisfaction questionnaire with today's program and how to get your CME credit certificate emailed to you. If you don't like that technique and you're high tech, you can use your QR code reader on your cell phone or your iPad or your laptop, and you can scan the funny looking checkerboard on the screen. And what it will do is it will automatically take you to our website. And once again, you can fill out your satisfaction questionnaire and you can get your certificate for your CME credit for today's program. We offer this CME credit as a free service of New York Medical College and Touro University. And we hope those of you seeking credit will avail yourself of the opportunity. But as I said, you've got about 3 days to do it before the codes expire. Now, we're going to go back to our program, but remember that if you have any questions for any of our panelists, go to that Q&A box on the screen, pose your questions, and we'll get to as many of them as possible during the Q&A part of our program. Once again, thanks for joining us, and let's return to our program.
Hi, my name is Diane Lindsay Adler. I'm a registered dietitian. I work for Boston Children's Health Physicians, here today to talk about nutritional supplements and if they're worthwhile. I have no conflicts of interest to disclose. So what are dietary supplements? Under the U.S. Dietary Supplement Health and Education Act, the DSHEA, they are intended to supplement the diet, They contain one or more dietary ingredients, for example, vitamins, minerals, herbs, amino acids. Collagen seems to be popular right now. They're intended to be taken orally as a pill, a gummy, a tablet, a liquid, or other form. And they're labeled as a dietary supplement. Dietary supplements are not intended to treat, diagnose, prevent, or cure diseases, and they're regulated as a food category rather than as a drug category. And they boast a myriad of health-promoting claims, including immune support, increased energy, decreased menopausal symptoms, more muscle mass, cancer prevention, and help for hair, skin, and nails, and many, many more. According to the NIH, Americans spend about $60 billion annually on dietary supplements, and Haynes reports that from 2017 to 2020, almost 60% of adults and about 35% of children and adolescents had at least one dietary supplement in the past 30 days. Multivitamins and mineral supplements were the most commonly used, and that's what I'm going to focus on today, micronutrient supplements. So according to the Academy of Nutrition and Dietetics, their position paper says that routine, indiscriminate use of micronutrient supplements for the prevention of chronic disease is not recommended given the lack of available scientific evidence. Micronutrient supplements, they are warranted when requirements are not being met through the diet, and there can be special needs, for example, secondary to growth, chronic disease, medication use, malabsorption, pregnancy, lactation, and aging. All of these may be at risk for inadequate dietary intake. According to the AAP, the American Academy of Pediatrics, exclusively or partially breastfed infants do need a vitamin D supplement until they wean off and start drinking whole milk, which is vitamin D fortified. Supplemental iron, which is 1 milligram per kilogram per day from 4 months until they start consuming iron-rich foods, around 6 months is needed. But infants who have to receive formula, which is fortified with vitamin D and iron, typically don't need that supplementation. All children should be screened at 1 year of age for iron deficiency, and routine use of multivitamins in well-nourished children does not appear to provide significant additional health advantages. Is there any benefit? So there are 3 studies I found that show that for the general population, routine use of vitamin and mineral supplements does not significantly improve health outcomes in terms of preventing major chronic diseases or extending the lifespan. So the first study was a comprehensive systematic review in JAMA in 2022 that evaluated the efficacy of vitamin and mineral supplements in preventing CVD among adults. So that study concluded that insufficient evidence exists to support the use of multivitamins or individual vitamin and mineral supplements. And notably, they found that beta carotene and vitamin E could be associated with an increased risk of lung cancer among individuals who smoke. In the second study, it was published in June of 2024. A large analysis of data from nearly 400,000 healthy US adults followed for more than 20 years, found there was no association between regular multivitamin use and lower risk of death. And then the third study, which I like, the 2019 study out of Tufts, showed that nutrients from food, not supplements, were associated with lower all-cause mortality. This is just a chart showing the US Preventive Services Task Force conclusions. And at the bottom, I highlighted what they came up with, which is very similar to what the study that was shown in JAMA in 2022 showed. And they concluded that the evidence is insufficient to determine the balance of benefits and harm of supplementation with multivitamins for the prevention of cardiovascular disease or cancer. And they also concluded that the evidence is insufficient to determine the balance of benefits and harms of supplementation with single or paired nutrients other than beta carotene and vitamin E, which they showed they did not recommend for the prevention of cardiovascular disease or cancer. So there are some new studies showing a slight benefit to multivitamin use. The cocoa supplement and multivitamin outcome study called COSMOS investigated the effects of daily multivitamin supplementation on cognitive function in older adults. This study had over 21,000 participants aged 60 and over, and it was randomized to receive either a daily multivitamin or a placebo. And the primary outcomes assessed were changes in global cognition and episodic memory for 2 to 3 years. So for global cognition, they were taking the multivitamin exhibited significant improvements in global cognitive memory. That means memory and executive function compared to the placebo. And for episodic memory, which shows that a multivitamin may help preserve memory function in older adults. So there are special conditions requiring supplementation, and that would be in infants, as I mentioned before, by the AAP. They may need vitamin D if they're breastfed, and also iron. For persons with malabsorption issues, they may need extra vitamin supplementation. For example, I work with patients that have cystic fibrosis. They require extra fat-soluble vitamins A, D, E, and K because they have difficulty absorbing fat. For women of childbearing age, they may need folate and iron. Older adults may need calcium, vitamin D, and especially vitamin B12, as stomach acid decreases and it's harder to absorb the B12. Also, vitamins for older people with macular degeneration may be needed. And much of the population may need vitamin D to decrease sunlight exposure, especially up in the Northeast. Here are micronutrients that could be a special concern. As I mentioned before, vitamin D, because it's hard to get from food and sunlight. Calcium requirements increase with age. So we need about 1,200 for older people. And it's really hard to fill that gap from our diet. So oftentimes we need to have a supplement of calcium, but just to be careful not to go over 1,000 milligrams a day. Only supplement what's needed to fill that gap to reach 1,200 milligrams per day. Vitamin B12, again, adults over 50 malabsorb and they require supplementation, as well as vegetarians and vegans need extra vitamin B12. Folic acid is required for pregnancy and iron, infants, children for pregnancy, women of childbearing age, and for vegetarian and vegans, they need iron. Are supplements safe? Clinicians and patients should be aware that the US FDA is not authorized to review dietary supplements for safety and efficacy prior to the marketing. So in the US, dietary supplements are regulated by the FDA, but that means that these firms are responsible for evaluating the safety and labeling of their products before marketing to ensure that they meet all the requirements of the Federal Food, Drug, and Cosmetic Act, as amended, as I mentioned before, by the DSHEA in 1994 and FDA regulations. Can too many vitamins be harmful? Absolutely. So I'm listed a few that are very important. Vitamin A in excess of the preformed vitamin A form, which is retinol, can cause liver toxicity. And more than 3,000 micrograms of retinol a day can cause birth defects. Beta carotene, as mentioned in the previous study, high doses of beta carotene raise the risk of lung cancer in smokers and former smokers. Excess calcium intake can be linked to an increased risk of cancer death and kidney stones. And we want to make sure we never take more than 1,000 milligrams a day of a calcium supplement. For iron, excessive iron intake can lead to toxicity, especially in children. The upper limit is 40 milligrams a day for children under 13 and 45 milligrams a day for those aged 14 and older. Excess vitamin D can cause hypercalcemia, and severe toxicity may cause abnormal heart rhythm and calcification of soft tissues. High doses of folic acid can mask vitamin B12 deficiency and lead to neurological damage. And high levels of zinc can interfere with copper absorption. And people use zinc lozenges all winter long, and they could go over the limit for zinc. The dietary guidelines for Americans 2020 to 2025 emphasize obtaining essential nutrients primarily through a balanced diet rich in nutrient-dense foods and beverages. So, for example, I recommend to all my patients a mix of all of these foods that are on the My Plate. Vegetables, especially those with dark green, red, orange color, beans, peas, lentils, starchy, and other vegetables. Protein foods that are lean, so poultry, eggs, seafood, beans, peas, lentils, nuts, seeds, and soy products. So protein can be plant or animal-based. Low-fat dairy, so yogurt, cheese, and fortified soy alternatives if you can't tolerate dairy. Fruits, especially whole fruits instead of juices. Whole grains, which have more fiber in them. And then oils, which are primarily plant-based, like seafood and seafood and nuts. These guidelines suggest that nutritional needs should be met primarily, again, from nutrient-dense foods and beverages. But they also acknowledge that in certain cases, as mentioned before, specific populations might need additional supplementation. So what's the correct dose? Healthcare providers can find evidence-based guidelines on the correct dosage at the link that I listed below. The National Institute of Health Office of Dietary Supplements provides very helpful handouts for healthcare providers that list the RDA, the upper limit, and all the considerations for specific populations. So in conclusion, a multivitamin can't fix a poor diet, as we saw in the study, the 2019 Tufts study. It's advisable to get micronutrients from a healthful diet of fruits, vegetables, whole grains, lean protein, and low-fat dairy or dairy alternatives. Older healthy adults, again, should take the B12 supplement and consider calcium and vitamin D based on their intake. And then also for age-related macular degeneration, we found that there are a mix of eye vitamins that are helpful. And the multivitamins for cognition we just saw from that new study, the Cosmos study. Most people will need and benefit from a vitamin D supplement because we don't get enough from our food or from sunlight. Infant and children should be supplemented with iron and vitamin D as recommended by their pediatrician. Women of childbearing age may need additional iron, and pregnant women should take folic acid supplement. Thank you so much. Here are my references.
Well, good afternoon. This is your host, Dr. Edward Halpern, and there are a lot of questions for our panelists today. First, several of you have written in questions for Dr. Jacobson asking about the role of EKGs on what you're wearing on your wrist, your smartwatch, asking what the value is of those for medical screening. Dr. Jacobson at the moment is in the cardiac cath lab taking care of patients, so he cannot join us live. Please type in the Q&A box your email address, and I will pose this question to him when he's out of the cath lab so he can answer you by email. I'd like to start with a first question for Dr. Chouinard, if she could join us, please. Dr. Chouinard, one of our listeners has typed in the Q&A box, if a sibling died from metastatic lung cancer, and my sibling was a non-smoker, and I am a non-smoker, am I a candidate for screening based on family history?
Yeah. So it's a great question. We know that maybe 20 to 30% of lung cancers are in patients who are non-smokers. Currently, the only recommendations right now that will be covered by insurance, and there's evidence to support it, are patients with the eligibility criteria I mentioned before. So they are for smokers or former smokers between the ages of 50 to 80 who have a 20-pack year smoking history. However, there's a lot of efforts being made to come up with criteria that non-smokers we could use for non-smokers. So we oftentimes use a risk-based calculator to identify different risks for patients. However, there is not huge amount of data to support using that, and there's questionable whether it would be covered by insurance. So for right now, the answer is no. We're still working on many ways to be able to screen non-smokers for lung cancer. Right now, the most evidence that we have supports screening in patients that are considered high risk. And unfortunately, right now we're using risk-based calculators, but there have been no recommendations made by the United States Preventative Task Force for non-smokers as of yet. But we understand that actually we know a risk exists.
All right, so the answer is it wouldn't be recommended by the guidelines, but even if your healthcare provider was tempted to recommend it, you're going to pay out of pocket for it because the insurance company probably won't.
Correct.
Yeah. Okay. Let's give you a break. We're going to come back to you because you've got a long list here, but we're going to ask Professor Lindsay Adler to come on along with Dr. Hendricks, please. And here comes Professor Lindsay Adler. We've got two variants of a question about vitamins for children. I'll personalize it. When I get ready to give my 5-year-old granddaughter ready for her bath, she opens up a drawer in the bathroom, takes out a bunch of bottles with brightly colored gummies, and lines up all her vitamins that she's supposed to take. And as I recall, there's 3 different bottles, including one with a prescription label on it, in an otherwise healthy 5-year-old. And Tammy in particular, I remember when I was a young doctor, one of the companies used to run ads in the medical journals, and it showed an earnest-looking woman looking at you from the ad and a little child sitting on the examining table. And the mother is saying, "Oh, doctor, they're such a picky eater." And then the message was, "Prescribe such and such vitamins," as if you could get this mother off your back by writing a prescription or a recommendation for vitamins. So, Professor Lindsay Adler, you said about a third of American kids are on vitamins. Is this really necessary? I mean, you mentioned low iron and breastfeeding, but I think a lot more kids are taking vitamins than that. Let's start with Tammy Hendricks first, and then go to Professor Lindsay Adler. We'll do it in alphabetical order.
Thank you. I love this question, and it is definitely something that I address almost every time I'm in the clinic. It certainly seems to be a lot of parental assumption out there that you could fix a variety of issues if your child would just take some vitamins. So, are they necessary in a healthy child who doesn't have any absorption issues or feeding issues or anything related to that? Do they need vitamins? No. Ideally, they'd be getting all of the vitamins and minerals that they need through the foods that they're eating. I love the background in Professor Lindsay Adler's office, which I'm imagining that it has the whole rainbow there of fruits and vegetables. If the child is eating the rainbow, then it does have the rainbow. If the child is eating the rainbow, then they're receiving the nutrients that they need. So no, most children, even picky children, do not need to take supplemental vitamins. Thank you for the question.
Professor Lindsay Adler, they're such a picky eater. Don't they need vitamins?
That's a great question. And I am in agreement that they most likely do not. However, I do have some extremely picky children that won't touch a fruit or vegetable. And that's kind of like insurance for the parents that they can take a multivitamin. It's relatively safe. But I do get nervous if you've got multiple vitamins in a drawer, because as you saw in my presentation, there is risk for taking too much of certain nutrients. And you're taking multiple vitamins, you might not even realize that you're going over.
Okay. Well,
Thank
thank you.
you.
Let's let Dr. Hendricks take a break and keep Professor Lindsay Adler on. We've got two more questions specifically for you. If it's a dietary supplement and not as strictly regulated as a drug, the questioner wants to know, how do I really know what's in this pill besides what the company claims is in this multivitamin pill? Who's really watching to be sure what the contents are?
That's a very big issue because they are put on the market before they are looked at for safety. So you're relying on a company. There are some resources out there like consumerlabs.com and different outside entities that will look at the quality of vitamins, because our system right now lets them on the market first before then they get reports of adverse reactions. So it's a little scary unless you get a common brand, like, for example, Centrum Silver or something like that.
Okay. And what is one to make about food products which are marketed as fortified with vitamins? There's a lot of stuff being sold in the market where you're supposed to want to buy it because it says on the label, such and such a vitamin added.
Well, I mean, that's regulated and that's on the nutrition facts label and on the ingredient label. So I would feel confident that many cereals are fortified with vitamins and they do have those vitamins.
Okay. Stay with us. Can Dr. Karen Murray join us? Because we've got a question in the box for both of you about prenatal vitamins. Who needs them? Does everyone need them? How do you decide? So we'll keep going in alphabetical order. We'll have Professor Lindsay Adler first and then Dr. Murray.
I think they're absolutely necessary. Folic acid is very important and should be started even before, when we're thinking about becoming pregnant. And as I said in the chat, I would just count on my obstetrician to recommend the best brand for a patient that needs a prenatal vitamin.
Okay.
Thank you.
Dr. Murray?
Yes, Dr. Halpern, I 100% agree with Lindsay, Professor Lindsay. Prenatal vitamins are recommended to be started prior to getting pregnant. And I whenever I have someone comes in for preconceptual counseling, I do recommend starting your prenatal vitamin before you get pregnant. Prenatal vitamins give you extra vitamins and minerals that you need during the early part of pregnancy. There are many people who don't know they're pregnant until they're almost 3 months pregnant. So that's part of the reason why, if you're thinking about becoming pregnant and you're going to be going down that pathway, we do recommend starting prenatal vitamins ahead of time. Most vitamins, they're not recommended for daily, for people who are not planning on getting pregnant. It's not recommended for every woman to take them. But if you're actively thinking about getting pregnant, we do recommend starting to take them. What are the side effects of prenatal vitamins? Very little side effects. Maybe the iron may cause constipation, or some people complain of nausea. So sometimes we recommend taking it at night. But in terms of for the pregnancy, we really still recommend taking these prenatal vitamins prior to getting pregnant. Thank you for the question.
Thanks to both of you. Karen, we're going to let you take a break. Ashley or Michael, we have had so many people type their email addresses into the Q&A box. Could I trouble you to write those down, and I'll keep posing questions? I might be able to multitask, but I can't MC and write down all those email addresses.
I will take care of it.
Thank you, Michael. Professor Lindsay Adler, one of our questioners wants to know your opinion about stopping in at the mall for IV vitamin infusions, which some people are marketing.
From all the research I've seen and commentary I've seen in the nutrition world, that's not necessary. Maybe if you had a malabsorption issue, you could do a subcutaneous vitamin or something, but I don't think it's necessary to spend all that money on IV vitamins.
Okay.
Thank you.
And we have a questioner who is raising a topic that we devoted a webinar to about a year ago, which is, can anybody in medicine make up their minds about routine vitamin D? They're sending people for their vitamin D levels at their yearly physicals. They keep changing what the definition is of normal, and we have a lot of people taking vitamin D. You want to weigh in on this one? The last time we tackled this, we had an endocrinologist who showed us a bunch of studies saying it doesn't make any difference. Stop doing it. And then I got a bunch of people emailing in saying, oh, I didn't like that study. What's your opinion on the vitamin D story?
I think we should follow the guidelines and give 400. It's a range of 400 to 600 IUs per day. I think it's important for absorbing calcium and for bone health.
Yeah.
It's too hard to get it from food and sunlight. Thank you.
Okay, we'll thank you. Let's give you a break. We got a tough one for Dr. Murray. Let her back on. We got someone who might be vying here, Dr. Murray, to be a legal cross-examiner here. You said a doula needs to take a 16-hour course. Now, you obstetrician gynecologists went to medical school for 4 years, 4 to 5 years of residency training, right? Are you really saying it's a choice to have a birth attended by someone with 16 hours of training compared to close to a decade? It's not a perfectly neutral question, Dr. Murray.
Thank you, Dr. Halpern. I think I should just reiterate. A doula is a lay person. They're not medically trained at all. And I am in no way recommending that you substitute an obstetrician for a doula. A doula is qualified as a labor coach. So they're there to support mom through her pain and her delivery. The birth attendant that you would have at home would be a certified nurse midwife or a certified midwife. To become a certified nurse midwife, you'd have to finish nursing school and then get a master's in midwifery. To be a certified midwife, you'd have to take the midwifery program through their school and get an MSN. You'd have to complete that. Once you've completed that, you'd have to get your national certification. You'd have to be licensed by the state And you'd have to keep up with your continuing medical education to keep your certification. So it's a lot longer process to be a certified nurse midwife. And a doula is just really there to kind of hold mom's hand, rub her back, give her massages, help her out as she's in labor. So you can have a doula in the hospital and you can have a doula at home. So they're really there just as a labor coach, not to substitute for your obstetrician, not at all. Thank you for the question.
Thank you, Karen. We got a tough one for Dr. Hendricks. We'll let Dr. Murray off the hook for a while. The questioner, Dr. Hendricks, wants to know, what about all of those prenatal ultrasounds? Women give birth often in the United States, having had multiple prenatal ultrasounds. How do the results of those ultrasounds affect what the pediatrician does or doesn't do in a newborn physical? Indeed, the questioner wants to know, does the pediatrician even know what all those ultrasounds show when they walk in to examine the baby?
Yeah, that's a great question. Thank you. Every newborn should receive a thorough physical exam, ideally by a pediatrician or a clinician who's trained to do so, regardless of any prenatal results. That being said, knowing the results of the prenatal ultrasound, and most of the time if the prenatal ultrasound was abnormal and the mother is giving birth in a hospital or a birthing center, the clinician who's going to be observing the infant that is aware of those ultrasound results, and it may help to guide the pediatrician to look for different factors. You know, you might be looking for the overall health of the newborn is what we're looking for in general. We're looking for some common abnormalities, but if we know specifically that something is wrong with the newborn's heart, for example, we may pay closer attention to other parts of the newborn exam, and we may refer the patient for other testing. There are also some congenital abnormalities that run together that are often seen in certain disorders. And so we may, look more closely at the newborn's ears or at different parts of the newborn to see if we're looking for an overall abnormality of the newborn. Thank you for that question.
Interesting. Thank you. Dr. Chouinard, we've got a list for you we'd better tackle. So we'll let Dr. Hendricks take a break. You with us, Dr. Chouinard? There
I
you
am.
are.
Sorry. Take a second.
Someone has typed in the Q&A box. They want to know the difference in cost for a chest X-ray and a low-dose CT for screening.
Okay. So chest X-ray is not recommended for screening, so it wouldn't be covered for screening. It's actually mandated for Medicare, Medicaid, and also private insurers to cover, an evidence-based screening tool. So there should be no copay for a low-dose CT if eligibility criteria is met. I'm not sure if that answers the questions a little bit better, but in terms of cost, I think I've seen that a low-dose CT can cost anywhere between $250 and I've seen ranges between $200. It depends. For a specific low-dose CT, I think roughly about $250. An X-ray I've seen range from $100 to $250 as well. I guess it depends what part of the state you may be in, but in general, those aren't numbers you come across often. I think the bigger point is to understand that if you meet screening tests should be covered by insurance, and if you meet eligibility criteria, there should be no cost to you.
Okay, thank you. Well, we've got a particular screening population question. The questioner writes, they used to require public school teachers to have a yearly chest X-ray to screen for TB, lest it be spread to the school children. That's gone away. But with the reemergence of tuberculosis in some parts of the U.S., should we be talking about that again?
So no, I mean, there's been more advanced technology now in using different things to screen for tuberculosis. So there's a blood test called quantiferon, which we routinely now use and is widely accepted as a screening tool for latent TB. So we no longer do chest X-rays as a screening tool. Now, if there are symptoms, right, of shortness of breath, cough, and those things, then you would do it. But you would not do a chest X-ray for screening for tuberculosis in that setting. What is being used is a quantiferon test, which is a blood test.
I'm old enough that I used to be a public school substitute teacher, and I remember the van pulling into the parking lot with the mobile chest X-ray unit. Everybody line up for your chest X-ray for the school year. You know? Okay, so technology has supplanted that.
Right. So oftentimes, if your quantiferon is positive, then that might prompt a chest X-ray, but not first. Correct. Thank you for the question. It's a very good one.
We have an interesting one here. The author talks about an article this week in a medical journal that raises the concern about overdiagnosis from imaging for lung cancer screening. The authors of this medical journal article cite a large study in Taiwan and focus on whether more harm than good is being done by overdiagnosis of nodules on CT. In particular, the article raises a concern about extremely slow-growing lung cancers which do not merit treatment. They say that some lung cancers are, in the elderly, like prostate cancer, so slow-growing they don't need treatment. The questioner writes, I thought lung cancers were highly lethal. Indeed, you showed a slide about most being advanced. Is there really an entity of extremely slow-growing lung cancers that we are overdiagnosing?
100%. I mean, that's actually one of the downsides in lung cancer screening, is that you are going to pick up nodules that may not be cancers. So there's a huge element to when you're screening for lung cancer that's called shared decision making, where you have a conversation with the patient and you inform them of that possibility, of the fact that there may be nodules that pick up, and you may, get recommended to do a biopsy, and it turns out to be negative. So in the end, this is still just a recommendation, but the patient gets to choose. The data is presented to them, but that is a huge part of a shared decision-making discussion. And yes, to answer your question, there are types of cancers that are very slow growing. And actually, you follow them a little bit differently based on some characteristics. So you take the interval of time between serial CAT scans may vary, understanding that they may be slow growing. So there are times where you don't do anything but watch. So that is very true. There are slow growing cancers. We're aware of it. And we oftentimes will watch. There's a lot of surveillance before we intervene, because we understand that, something else may kill you before that cancer actually does. But that's also something that is discussed in shared decision making. And when we review the results of your low dose CT.
Right.
The more aggressive cancers are usually, the characteristic of the nodule is they're a lot more solid. If they might have referred to this in the article, the slower growing cancers have different characteristics on CAT scan. And so you understand sort of how you should follow those, which is a little bit different than how you would follow the more solid nodules. Thank you for the question.
Before you leave that point, talk to us about these nodules and people who've been in the Ohio River Valley, what they used to call river disease, various fungal entities, which can be confusing.
Okay. So the last thing you want to do is biopsy an infection. So we are aware that one, you want to be thinking about the risk factors of our patient, right? So like if patients have risk factors for lung cancer, it's always on the differential. Usually infections, they wax and wane, or there's changes. So, and there's characteristics that may be more consistent with an infection. So not every nodule to us means cancer, but you follow it as if it were, in the sense that, like, I'm waiting. If it resolves, if it gets smaller without any intervention or with antibiotics, we understand that they may be more likely infectious. If they're from certain regions, or we compare to a previous CAT scan and that wasn't there maybe 2 months ago, it's unlikely that it would be malignant. So there's other things that we're considering when we're evaluating these abnormalities on CAT scan. So yes, we are keeping in mind that these nodules could be other things, and there are multiple factors in deciding if it could be something benign. And if that is a suspicion, we follow until it resolves, it gets better, or sometimes we intervene and would treat something empirically to see if there's any change, because that would be less likely cancerous. If that would, I'm not sure if that clarified your
No,
question.
it does. Yes, thank you. Thank you very much.
Thank you for the question.
Let's get Professor Lindsay Adler back on the screen. You have been furiously typing answers in the Q&A box, but some of your answers, I think the whole audience ought to hear in addition to the individual questioner. More than one person has asked, how do you know what's a reliable brand for vitamins? And I see you typed an answer to one of the questioners, but tell the audience what they should look for if they want to look for a more reliable brand for vitamins.
I look for like a third-party certification again, since it's not required to be put on the shelf to be safe by the U.S. DA or the FDA. I look for the USP or like I said, the consumer lab that have looked at these and put their seal on them. Oftentimes, do you like me to name names or not on this webinar? Is it okay? I sometimes look for Nature Made. I think it's a very good.
We don't want to endorse particular brands here, but if it's okay to say what certification agencies you find.
Right. I look for USP mostly. That's an important one for me. I've read about it, and consumer labs. And, within all my dietary, my nutrition publications and blogs and things like that, I figure out which brands I prefer to tell my patients to use.
USP is an abbreviation for United States Pharmacopoeia, right?
Yes.
Yeah. A very venerable organization in the United States. Let's wrap up with this interesting question. California may mandate folic acid in bread, and under a recent change in the law, corn flour products. Are they putting enough folic acid in these to obviate the need for prenatal vitamins?
I just don't think you could ever know if that was enough. And I would absolutely say still take your prenatal vitamin.
Okay. Thank you. Thanks to all of our panelists this afternoon. Thanks to the audience for an unprecedented number of questions. We hope you found this a useful activity. We will see you all again next time. Watch for announcements. We're broadcasting about every 4 to 6 months. As always, if you have topics you wish to hear about, you be sure to email us. Have a good afternoon. Thanks for joining us, and stay safe, and happy holidays to everyone, and a happy and healthy new year. Bye-bye.